Hi, everyone. Welcome, welcome. I'm happy to see you all here today. Today, we're going to be talking about acid-base balance. This is a really big topic on the NCLEX, and I'm really excited to share what I have with you. How's everyone doing today? Hope you're all doing well. So, I'm going to go ahead and get started here. I was just waiting a couple minutes to see if we have any more participants joining, and if we do, then they will continue to join as we start our soft intro here. My name's Maria. I'm a registered nurse, and I'm tuning in from Southern California. It's about 6 p.m. over here. Welcome to everyone all around the world. Let me know where you're tuning in from, and make sure that you get yourself comfy. We're going to be together for the next 2 hours. Get whatever you need to take notes with, whether it's a tablet, a notebook, a computer, and get yourself a nice drink like a tea, a water, coffee, and some pillows. And get ready to break down this topic with me, take some notes. I'm going to tell you a little bit about how this webinar is going to go. We are going to cover our topics based on our slides I'm going to share with you. And I am going to guide you through some concepts today having to do with acid-base balance. You are very much welcome to drop any questions, comments, feedback, or requests in the chat anytime throughout the session. I will pop back in here and there from looking at the slides to looking at the chat and answering questions for you guys and addressing everything that you say to me. I will try to get around to everyone. And in the middle of the webinar, I will give you a little break so you can use the restroom, stretch your body, get a break for your brain. And my goal today is to make sure that you guys are leaving feeling more confident and having all your questions answered about this topic. Since we do have limited time, I will try to get through everything, and then we will do some application questions at the end. And of course, I will give you guys opportunities to participate and to chime in. Hello, joining from Kenya. Welcome. And let me know in the chat if you guys have seen me before or if you're new to my webinars. I do teach 3 topics. I teach maternal newborn health, adult health, and fundamentals here at Naxlex. And I'm excited to meet all of you. You may have seen me in the test banks. You may have seen me in some webinars before. I've worked in various areas of healthcare, so feel free to ask away, and I will be more than happy to share my knowledge and answer questions for you guys. Well, let's go ahead and get started and kind of talk a little bit about what we are going to tackle today. So I'm going to give you a little overview of our topics. We are going to talk about hydrogen ions, acids, and bases. We're going to talk about regulatory systems for hydrogen ion concentration in the blood. We're going to go over respiratory acidosis and alkalosis, and also metabolic acidosis and alkalosis. We're going to talk about compensation, steps for analyzing ABG results. We got a little typo in there. Sorry about that. And NCLEX strategies and practice questions. So I want to welcome you to our acid-base balance webinar. This is one of the most clinically important and NCLEX tested physiology topics. So here's the big picture. The human body has to keep the blood pH between 7.35 and 7.45 for cells to function. We know the very narrow window. Hi, is someone saying something?
You are ignoring me.
Oh.
I won't answer your phone call anymore next time.
I think somebody's unmuted. I'm going to go ahead and mute you, okay? I think we have some participants that maybe didn't know that they were unmuted, but I went ahead and muted. But if you guys do have a question, feel free to unmute and ask me. Or if you can't see something like the screen is not showing up correctly or you can't hear me, please let me know. I'll be more than happy to fix it. All right, so let's talk about it, right? So 7.35 to 7.45, this is a very narrow window that the human body has to keep the blood pH in order for cells to function. Now, outside of this range, any enzyme activity, oxygen transport, and neurologic function are going to be affected by variations. And there's three major systems that actually regulate the acid-base status in the body. We have buffers like bicarbonate, which we call bicarb, right? These are the ones that respond immediately by binding or releasing hydrogen ions. Now, think of them as kind of like the first line of defense. They're quick, but they are limited. Then the respiratory system compensates also within minutes by adjusting carbon dioxide, which does act as an acid. Now, breathing faster means we're blowing out CO2, which could mean alkalosis, right? If we don't have enough acid, our system becomes alkalotic. Breathing slower means we're retaining CO2, which means acidosis. Now, we're going to go deeper into it. That's just a small example. And third, we have the renal system, right? The kidneys. These are going to be a lot slower to compensate. It could take hours to days, but it is a lot more powerful. The kidneys do excrete and reabsorb bicarb and hydrogen ions. So, a quick rule here to remember is that CO2 is an acid and it's regulated by the lungs. And HCO3, also known as bicarb, is a base and it is regulated by the kidneys. Now, if you remember, bicarb and base both start with the letter B, then you don't really have to remember that CO2 is the other one, which is the acid. Now, let me go over very quickly some red flags for the NCLEX, but of course, we're going to go into it more comprehensively in the next few slides. Now, acidosis could look like CNS depression. So, in this case, we're going to watch out for lower level of consciousness, hypotension, and bradycardia. Whereas alkalosis would look like central nervous system excitability. So, in this case, we'd be looking for confusion, tremors, and seizures. I want you to always ask yourself, what's the trend, what's the cause, and who is at risk? Now, the the NCLEX, as we know, is not just going to ask for definitions, right? The NCLEX is not really a what is this kind of exam. They really want you to recognize symptoms, they want you to intervene, and they want you to know how to prioritize care. So I'm going to share with you a little memory trick here. You may already know it, but if you don't, then write it down. And the word is ROME, and it stands for respiratory opposite metabolic equal. Now, we're going to use this later to interpret ABG values, so just keep it in mind. I'm going to give you a little mini clinical scenario here. If you have a patient that has COPD, they are breathing very shallow. Let's say they're breathing about 10 breaths per minute, and their ABG is showing a pH of 7.28. And their CO2 of a 52. Now, what do you think they're going through? Respiratory acidosis, alkalosis, or metabolic acidosis, alkalosis? Does anybody know?
Respiratory acidosis.
Yes, that is correct, right? Because the CO2 is high and the pH is low, which means we're acidotic, right? Good job. You should definitely be able to recognize respiratory acidosis, especially from knowing that this person is hypoventilating, right? So let's go ahead and jump into our main topics here. But before we do, I just want to remind you that if you have a normal CO2, it's likely not respiratory But if you have an elevated bicarb, this is likely metabolic. So let's go ahead and jump in. But first, let's do a bit of foundational work here by talking about hydrogen ions, acids, and bases. Now, we're going to break down the foundation of acid-base balance and hydrogen ions. So the blood pH is actually a reflection of how many free hydrogen ions are present in the bloodstream. Hydrogen ions are symbolized by that H with the little plus sign next to it. Now, the more hydrogen ions there are in the blood, the more acidic it is and the lower the pH. And the fewer hydrogen ions there are, the more basic it is and the higher the pH. And even really tiny changes in hydrogen concentration can drastically impact the body in lots of different ways, in neurological function, in cardiac contractibility, and in delivery of oxygen to the tissues. This is why the body has to work really hard to keep the blood pH between 7.35 and 7.45. So let's define some terms here. Now, acids are substances that actually donate hydrogen ions. For example, carbon dioxide forms carbonic acid in the blood. And bases are substances that accept hydrogen ions. So for example, bicarb is going to bind hydrogen ions to reduce acidity. So, when carbon dioxide rises, like in COPD or in hypoventilation, the blood actually becomes more acidic, right? Because we're not able to expel as much carbon dioxide out of the body, so it's building up in there. Now, when bicarb rises, like from excessive antacid use or excessive vomiting, we're losing acid, right? So bicarb is excessive. Now the blood is going to become more alkaline. So an NCLEX concept for you to remember here is that carbon dioxide behaves like an acid and bicarb behaves like a base. Your job as a nurse is actually to track who is causing the shift and how the body is compensating for it. So a memory trick here is to think carbon dioxide is acidic, think carbonic chaos, and bicarb is basic, think bicarb is the balancer. All right. So let's say you have a client that has very slowed respirations, like 6 breaths per minute after you gave them some opioids for pain, right? You know that they're retaining CO2. You're expecting hydrogen ions to rise, which means this person is going to be in an acidotic state. So on their ABGs, you're most likely going to see respiratory acidosis. All right, let's go ahead and move on to the next topic here. So we're going to talk about some regulatory systems for the hydrogen ion concentration in the blood. This means we're going to look at how the body actually regulates the pH, not just how it shifts, but how it gets corrected by the body. This is actually critical for both patient care and for NCLEX success. So your first buffer system, which are the first responders, are going to be, this is going to take place in seconds, by the way, as far as time goes. It's going to be bicarb, right? And it's going to be called your buffer system. So the bicarb buffer system is actually going to be the primary one in the blood that's going to act very quickly to bind or to release any hydrogen ions in order to neutralize any small shifts in the pH. So for example, when hydrogen ions are high, we have acidosis, right? And that means that bicarb is going to bind to the hydrogen ions in order to bring the pH back up. Now, we also have protein buffers like hemoglobin. These are going to help in the tissues. And we have phosphate buffers, which are going to be key inside the cells and in the renal tubules. Now, buffers are fast, but they are easily overwhelmed. They're like the first responders, but they go all out and they get easily overwhelmed. So our second system here is going to be respiratory regulation. This is going to be fast and it's going to be flexible. And instead of seconds, it's going to take minutes. Now, we know that the lungs control how much CO2 is, expelled or stays in the body. which also kind of indirectly controls the hydrogen ion levels, right? Because if the pH drops and we become acidotic, the body is going to compensate by increasing the respiratory rate in order to blow off the CO2 and reduce acidity, right? So if the body picks up that, the body is becoming acidotic, now it's going to trigger breathing to become faster so that we can blow off more CO2. Now, if the pH rises and the body becomes alkalotic, the respiratory rate is actually going to slow in order to retain the CO2 in order to increase the hydrogen ions and balance out that bicarb. Now, this response is very quick, but it's less effective than the kidneys in the long term. Remember, we talked about renal regulation in the very initial mini overview. Renal regulation is going to be another regulatory system here for acid-base balance in the body. This is going to be a very slow system, but it's going to be strong. It's going to take hours to days, but it is going to last longer and it's going to have a stronger effect. Now, the kidneys are actually the powerhouse of acid-base balance in the body. And the reason why is because they can reabsorb or they can excrete bicarb and they can excrete hydrogen ions. The system is going to be a lot slower than, let's say, breathing or the initial buffer systems that we talked about, but it is going to provide lasting correction in the body. So, for example, let's say in chronic respiratory acidosis like COPD, the kidneys are retaining more bicarb in order to balance the acid. Now, the memory trick here is going to be buffers, blink, lungs, minutes, and kidneys, commitment. A little mini scenario for you here. Let's talk about it. So let's say you have a patient and they're in DKA, right? Let's say that they're having very rapid, deep breaths, which are called Kussmaul respirations. What is happening here is the respiratory system is actually trying really hard to compensate for the body having metabolic acidosis by blowing off excess CO2. So that is what's going on. Now, let's talk about another NCLEX practice here. Let's say a nurse is caring for a patient that has chronic kidney disease. What acid-base balance or what acid-base imbalance do you think this patient is at greatest risk for? What do you guys think?
Acidosis?
Yes, it's metabolic acidosis.
Acidosis, yeah.
Yep, exactly. And great job. And the reason why is because when you have chronic kidney disease, the kidneys actually lose their ability to excrete hydrogen ions and to reabsorb bicarb, which is going to lead to acid buildup and metabolic acidosis in the body. Great job. All right. Now let's actually get into acidosis versus alkalosis here. We're going to compare respiratory acidosis and alkalosis. Of course, this is one of the most testable concepts on ABGs and on the NCLEX. So let's start off with carbon dioxide, which we know behaves like an acid in the body. So anytime your patient is hypoventilating, they're retaining CO2, right? And the acid levels in the body are rising, and this is causing respiratory acidosis. Now, on the other hand, if they're hyperventilating and they're blowing off too much CO2, this is actually removing the acid and raising the pH, which is leading to respiratory alkalosis. Now, I want you to think when it comes to respiratory acidosis, slow breathing is going to lead to acid buildup in the body. And this can include conditions like COPD, like opioid overdose, right? Because we have respiratory depression, like airway obstruction and respiratory failure. Some signs that you might see in these patients would be lethargy, headache, shallow breathing, and of course, neurological signs like lower levels of consciousness. Now, all these are going to be signs of central nervous system depression because of the high CO2 in the body. Of course, as nurses, we need to know what our priority interventions would be. And this would be to support the airway first and foremost, right? To improve ventilation, maybe we would do that by repositioning, by administering oxygen. We're also going to anticipate intubation or BiPAP if the patient is decompensating rapidly, right? Now let's talk about respiratory alkalosis. I want you to think fast breathing means carbon dioxide loss. This is typically seen in panic attacks, in pain, in sepsis, or when the ventilator settings are way too high. These patients are going to present with dizziness, with tingling, and sometimes even seizures because of vasoconstriction in the brain. Now, as nurses, our priority is going to be to slow their breathing, right? We need to reassure them. Have you ever seen people in the movie like rebreathing into a paper bag? This is actually one of these like old classic methods to help you kind of maintain that CO2 in the body, right? And we're also going to adjust any vent settings if needed. Now, a clinical pattern recognition for the NCLEX, I want you to know, is a low pH and a high CO2 is going to equal respiratory acidosis. But a high pH and a low CO2 is going to equal respiratory alkalosis. And of course, we're going to go back and use that Rome mnemonic, right? Respiratory opposite. pH and CO2 do go in the opposite directions. Now, a memory trick here for you to remember is that for acids, CO2 is going to be high and the CNS is going to be sleepy. And for alkaline, CO2 is going to be lost and CNS is going to be zippy, meaning it's going to be all over the place, it's going to be hyper irritable. Now, let's talk about a mini clinical scenario here. If we have a patient that's post surgery and they're overly sedated, and now they have a very low respiratory rate of, let's say, 6. And we just did some ABGs. Let's say that their pH came back at 7.30 and their CO2 came back at about 58. This is going to be respiratory acidosis, right? And the cause is going to be hypoventilation. What do you guys think the priority is going to be for this patient? So, as the nurse, the priority for this patient would be for us to stimulate them, right? We need them to breathe deeper because they're probably breathing very shallow. Their respiratory depression is very low. So, we are going to go ahead and stimulate them. If we can reposition them to expand their lungs, we will. And of course, if needed, we are going to prepare to support their airway. Now, let's say you have a client that is on a ventilator, right? And let's say they start to become really agitated and they're lightheaded. You get their ABGs back and their pH is at 7.50. Their CO2 is at 28 and their bicarb is at 24. What do you think the imbalance would be in this case? And if anyone knows the answer, just shout it out.
Is there respiratory alkalosis?
Can you repeat the questions, Professor, please?
Yeah, absolutely. So let's say you have a client on a ventilator, they become agitated, they become lightheaded, and you get their ABG results back, and the pH is 7.50. Their CO2 is 28, and their bicarb is 24. What do you guys think the imbalance is
That's
here?
metabolic alkalosis.
It would actually be respiratory alkalosis.
Respiratory alkalosis.
Yes.
Sorry.
No, you're fine. Yeah. And you're on the right track. It is alkalosis, right? Because the pH is greater than 7.45, which means they're alkalotic. And of course, their CO2 is low, which means we have a respiratory cause here. And their bicarb is normal, which means it's not really metabolic. It's going to be respiratory. So, no, you guys did great. Now let's talk about metabolic acidosis versus alkalosis, right? These are two conditions that also show up, right? Just like the respiratory. Metabolic acidosis, starting with that one. This one occurs when the body is accumulating too much acid or it's losing too much bicarb. And some common causes can be, one of the first ones is actually DKA. Diabetic ketoacidosis, right? I mean, it says it right there, ketoacidosis, right? And this is because of ketone buildup in the body. Another cause can be renal failure because the kidneys can't excrete the bicarb or the hydrogen ions at that point. And diarrhea is another cause too, because the loss of bicarb, right? They're just stooling it out, stooling it out, stooling it out. Now there's no more bicarb left. So we have metabolic acidosis with that. Now, another cause can also be shock and sepsis because of the accumulation of lactic acid in the body. We know we always check for lactic acid with sepsis, right? So if there's an accumulation of lactic acid in the body, then we have metabolic acidosis. Now, in this case, the body would try to compensate by increasing respiratory rate in order to expel the acid, right? So you're going to think like Kussmaul breathing in order to blow off all that CO2. And some signs and symptoms that you might see would be this client would be drowsy, they would have low blood pressure, their skin may be flushed, they might have hyperkalemia, and they might have some really deep, rapid breathing. Excuse me. So the priority here for this patient would be to treat the underlying cause of the acidosis. So let's say if it was because they're in DKA, we're going to administer insulin, right? If they're in shock, we're going to administer IV fluids. We're going to give them fluid resuscitation. Of course, we're also going to support their perfusion and their airway. Now, when it comes to metabolic alkalosis, this actually happens when the body loses way too much acid or it gains way too much base. And some common causes can be vomiting, right? If you're vomiting, you're losing all that stomach acid, your body's going to become alkalotic. Or if you have continuous NG suction, which means, again, loss of stomach acid. Now, another cause can be the use of diuretics, which means hydrogen ions and potassium are being excreted and lost. If a patient is taking too many antacids or if there's too much bicarb intake, that can also be a cause. And in this case, the body would try to compensate by slowing breathing to retain CO2, but this compensation is actually a limited process. And some signs that you might see in your client if they are having metabolic alkalosis would be muscle cramps, tetany, hypokalemia, confusion, and slow and shallow respirations. Now, our priority here would be to replace fluids and electrolytes, especially potassium, and to stop any causative agents, like, for example, if they are getting continuous suction on the NG tube, or if they're getting diuretics. Now, an NCLEX clue here for you would be, if you want to know some of the causes of metabolic acidosis, we have a word and it's mud piles. And I actually didn't write it on here, so I'm going to go ahead and drop it in the chat for you guys in a little bit. But it's the word mud piles, and it stands for methanol, uremia, DKA, paraldehyde, and then it stands for iron, lactic acidosis, ethylene glycol, and salicylates. And I'm going to go ahead and drop that in the chat for you guys. I am going to give you a mini clinical scenario here. Now you have a patient that's been having severe vomiting for 3 days, and they're presenting with muscle weakness and confusion. Now their ABGs are showing a pH of 7.49 and a CO2 of 44. What do you guys think they have?
Metabolic alkalosis.
Metabolic alkalosis.
Absolutely. You're on point. It is metabolic alkalosis, right? And the reason why is because they're losing all that gastric acid from vomiting so much. Now, we're going to anticipate some treatment for them, right? We're possibly going to give them IV fluids and we're going to replace their potassium because if they are feeling that way, it's very likely that they are hypokalemic. Now, let's say a nurse is caring for a client that does have DKA, right? The ABG results that the nurse would expect would likely be acidotic. So they would likely have a lower pH, right? An acidotic pH, and they would likely have a higher CO2. Now, let's go ahead and talk a little bit about some mixed acid base disorders. So this is kind of a trickier topic, right? When we have mixed acid-base disorders, this means that the patient has two primary acid-base problems happening at the same time, not one imbalance and one compensation. Instead, it's actually two different systems that are both contributing to instability, and this is definitely possible. Now, how to recognize it, right? Let's say if both carbon dioxide and bicarb are abnormal in the same direction, like for example, both causing acidosis or both causing alkalosis, then the imbalance is definitely worsened. If they are in opposite directions, they kind of may appear to cancel out, giving you a false normal. If you see a false normal pH and this is what's actually happening, this is very dangerous and it's very easy to mix. So this is why when you see questions on the NCLEX that require you to evaluate all three ABG values, not just the pH, that is the point of that, is because in order to determine what's happening, you need to see all three values, right? So let's go ahead and talk about a little example here. If we have a client with DKA that is also having respiratory failure. Now, the DKA is all, of course, going to be metabolic acidosis, right? But the respiratory failure with hypoventilation is going to be respiratory acidosis. Now, together, this client is suffering from both metabolic and respiratory acidosis. And this can actually lead to a really severe uncompensated type of acidosis. Let's say their pH is showing 7.15, their CO2 is 55, and their bicarb is 14. Now, this may not be as obvious to you, right, that they're suffering from both. But the intervention here that you have to do is you need to treat both of them. You need to improve the ventilation, and you also need to correct the glucose and the acid buildup, of course, with insulin and with fluids. So you still have to treat both of them, and they can both be happening simultaneously. Now, another example would be, let's say this client is vomiting and they're having hyperventilation from anxiety, right? So if they're vomiting, we know that they are most likely going to be suffering from metabolic alkalosis from losing the acid. And then hyperventilating is also going to be respiratory alkalosis, right? Because they are losing all that carbon dioxide. Now, this double alkalosis can lead to their calcium being completely depleted, which can lead to muscle cramps, seizures, and of course, cardiac irritability. Our priority here would be to rehydrate and calm this patient, and of course, to monitor for hypokalemia and arrhythmias. We are very concerned with cardiac status. Now, I want to go ahead and tell you a little memory trick here for you to remember is if you think mixed equals mismatch or magnified, right? The mismatch means that pH is normal, but both values are abnormal. And then magnified means both systems are going in the same direction. Now, let's say a patient is presenting with very shallow breathing and they have been experiencing really prolonged diarrhea. Let's say that their pH is 7.10. Their CO2 is 58 and their bicarb is 14. What do you guys think is happening? Does anybody have any ideas?
Could you repeat again?
Absolutely. So let's say you have a patient that's presenting with shallow breathing and they're also simultaneously experiencing prolonged diarrhea. Their pH is 7.10, their CO2 is 58, and their bicarb is 14. What do you guys think is going on?
Respiratory
Respiratory
acidosis.
acidosis.
More of respiratory acidosis.
Respiratory
Yeah.
acidosis.
Yes, they are having mixed respiratory and metabolic acidosis
Metabolic.
in this case. Yeah. Both the CO2 and the bicarb are actually contributing to the acidosis. The pH is remaining really low. This is not compensation, right? It's a mixed disorder. So good job. You guys definitely spotted that one. And I do have some steps here kind of to help you analyze ABG. This is like the famous tic-tac-toe trick that everyone knows about. You draw a 3-column chart on scratch paper, and then you place each of the ABG values in the correct column. And the pH is going to be what determines if it's alkalosis or acidosis. And then you're going to match, of course, the carbon dioxide or the bicarb to the pH to determine the origin, right? So you're going to look at the pH. Is it low? Is it high? And then you're going to look, is it respiratory or is it alkalotic or metabolic, I mean. And then the value that doesn't match the pH is going to be the compensator. So then you're going to assess to see if it's uncompensated, partially compensated, or fully compensated. And we are going to talk about that some more. So I will go ahead and go into that as well. So I'll leave this up here for a second. And then we'll do a little application on the next 3 slides here. We'll look at some examples and see what you guys think. All right, here is an example for you. We have a pH of 7.3, a CO2 of 55, and a bicarb of 24. What do you guys think the diagnosis is here?
Respiratory acidosis.
Yes, respiratory acid.
Respiratory.
And do you guys think it's compensated or uncompensated?
What's the pH again?
It's
pH
compensated.
7.30.
Is uncompensated respiratory.
Correct.
Respiratory acidosis uncompensated.
Yeah, you're correct. It is uncompensated, right? Because the pH is still abnormal. There's no metabolic compensation yet. Now, the NCLEX nursing interventions that you would do for this person would be to support their airway and to monitor their level of consciousness, right? Because when you have respiratory acidosis, you have that CNS involvement, and you really want to make sure that you are supporting their airway first and foremost. Now, you may even anticipate the need for ventilation or Narcan if opioids were involved. Let's look at another example. So here we have a pH of 7.47, a CO2 of 47, and a bicarb of 30. What do you guys think?
Metabolic
Metabolic acidosis.
Compensated.
Say that again.
Metabolic acidosis.
Could be. Look again.
Metabolic alkalosis.
Can we get it? Can I get the parameters again?
Is respiratory
Acidosis.
Alkalosis.
So
Yeah.
this one is going to be metabolic.
Alkalosis. Yeah.
Yes, it's alkalosis. And the reason why is this is actually partially compensated because the CO2 is trying to compensate by becoming acidic, right? So that's the trick here. It is metabolic alkalosis, but the CO2 is trying to compensate. So you guys did great with your critical thinking too on that one. And it is kind of hard to see sometimes. Like I said, we're going to talk more about compensation. So in this case, I want you to replace fluids and electrolytes. Remember, we're talking about potassium a lot. Of course, if we have any diuretics ordered like Lasix, we're going to hold those because we don't want them to be losing any more potassium. And if they have any continuous suction on an NG tube, we're going to hold that as well. Now, for this client specifically, we also want to monitor for any dysrhythmias, and we want to monitor for seizure risk. Remember, when we have alkalosis, the CNS is irritable, right? Whereas when we have acidosis, the CNS is very slow. One more example. So here we have a pH of 7.39, a CO2 of 30, and a bicarb of 18. What do you guys think?
Respiratory alkalosis. Respiratory acidosis. Sorry.
It is acidosis, but it's actually metabolic.
Metabolic acidosis.
Yes, it's metabolic acidosis. And do you guys think it's compensated or not?
It's compensated.
Compensated.
It's within the range. Yeah.
Yeah, it's fully compensated, right? The lungs blew out enough CO2 to actually normalize the pH. So the pH is within range between that 35 and 45. So with this patient, the NCLEX interventions that you want to prioritize would be to address the underlying cause, right? What is the underlying cause? Is it diarrhea? Is it renal failure? Is it DKA? We're also going to check some labs here. We're going to check their anion gap, and we're going to treat their underlying metabolic cause, which is going to help to balance out whatever imbalance was going on. You guys did great. Okay, so now I have a little bit of a chart here for you on how to identify compensation, whether it's uncompensated, partially compensated, or fully compensated, right? If it is uncompensated, the pH will be abnormal. Usually only one system is abnormal. When it's partially compensated, pH is still abnormal, but both CO2 and bicarb are abnormal while one is helping. And when it's fully compensated, the pH is back to normal. Both systems would be abnormal, but the pH would be corrected. Now, let's say you have a low pH, but a high CO2, respiratory acidosis. High pH, low CO2, respiratory alkalosis. When it comes to metabolic, it's going to be equal, right? Remember that Rome mnemonic, respiratory opposite, metabolic equal. So for metabolic, if the pH is low and the bicarb is low, you have metabolic acidosis. Whereas if the pH is high and the bicarb is high, you have metabolic alkalosis. Now, the reason why this matters for your test taking is, of course, the NCLEX may have you interpret ABGs and anticipate what nursing action you need to take. And you're going to be expected to match labs with symptoms, prioritize interventions, and recognize dangerous trends, not just memorize ranges. So remember, it's all about application. So I want you to remember to ask yourself, what could have caused this imbalance, right? What organ system is responsible here? And how is the body compensating for it? And last but not least, we need to ask ourselves, what do I need to monitor, treat, or anticipate next? Does anyone have any questions so far? Awesome. And then I do have, thank you guys for answering here in the chat too. And I do have a link here for our Telegram group that was dropped in the chat for you guys. So you guys can, chat amongst yourselves and share tips and tricks with each other. My mouth is not working today. Tips and tricks with each other. And then I do see a question here. Please, why is it metabolic? So metabolic means that we have involvement with the kidneys, right? So let me go ahead here and go back to our metabolic acidosis versus alkalosis here. Again, this does occur when the body is either losing too much acid accumulating too much acid or losing too much bicarb. And it's typically going to be caused by the kidneys, or it's going to be caused by things like diarrhea or shock or sepsis. Of course, the body is going to use the respiratory system to compensate, like by causing the respiratory rate to increase in order to blow off more acid in the form of CO2. So that is why it is metabolic. I hope that answers your question. So I'm going to go ahead and give you guys a 5-minute break here. So you guys can take a brain break and get ready for some more practice. I have more practice questions for you. I also have a couple more topics here. I'm going to talk about the steps for analyzing ABG results and compensation. We're going to talk about some test taking strategies, and then I will go ahead and jump into our practice questions. So feel free to get up, stretch your legs, use the restroom, refill your coffee, and I'll be here. But we will be back on with our topic in like 4 to 5 minutes. So see you guys soon. All right, guys. And I did drop the presentation here in the chat. I did see you guys requesting for the document. And then, of course, remember next time when you do join in, there is always an option to download the presentation at that entrance to the meeting as well. And then they will also be posted in our previous webinar section after we post the recorded webinar as well. So, and you're very welcome. It is my pleasure. And I want to go ahead and pick back up here. Let's go ahead and jump back to our topic. We did talk about lots of stuff today. We're going to jump into compensation next. So let's go ahead and talk about compensation. Of course, this is kind of a trap on the NCLEX, right? It's a little bit complicated to understand. I'm sure all of you guys are pros at it already. You've been practicing tons, but it doesn't hurt to go over it again, right? So this is compensation is going to be the way that the body attempts to restore homeostasis when it senses that there is an imbalance in the acid base. It doesn't necessarily solve the problem, but it does try to normalize the pH by using kind of the opposite system. So when it comes to respiratory compensation, this can kick in within minutes. Since the lungs regulate carbon dioxide, remember carbon dioxide is acidic, the lungs would be triggered to breathe faster and to blow off the acid, which is the carbon dioxide, when the patient is in acidosis. Now, let's say the body needs to retain CO2, right? In the case of alkalosis, it would trigger the lungs to breathe slower. So an example here, in metabolic acidosis, the lungs are going to compensate by increasing the respiratory rate. And we did mention that multiple times throughout the webinar, but just right, they say repetition is the mother of all learning. So for example, Kussmaul breathing in DKA is an example of metabolic acidosis compensation. Now, like I said earlier, renal compensation does take hours to days, but it is the most effective and long-lasting one. The kidneys do retain or excrete bicarb, which is a base, and it also excretes hydrogen ions or reabsorbs bicarb in order to balance the pH. So an example here would be in chronic respiratory acidosis, like COPD, the kidneys would retain bicarb in order to buffer the CO2. Now, let's say we have a mini clinical scenario here. A patient has a pH of 7.36, a CO2 of 55, and a bicarb of 30. Now, we know the pH is normal here, but it's kind of on the low end, right? And we also know that the CO2 is acidic at 55, and the bicarb is basic. So this would actually mean we have fully compensated respiratory acidosis. Our next step here for this person would be, of course, to maintain airway support, to monitor them, and to continue oxygen or BiPAP therapy. Now, let's go ahead and do a quick practice question just verbally. I'm not in our application questions yet, but just kind of sprinkling them throughout here because I feel like practice questions when it comes to acid-base imbalances are like the easiest way to work it out in your mind. So let's say we have a client that has COPD. And let's say that we pull their ABG values and their pH is at 7.35, which is still within normal range, but on the very low end, right? Their CO2 is 60 and their bicarb is 32. What do you guys think this patient has? So in this case, again, COPD, right? We know they're most likely going to have respiratory acidosis. Their ABG values are showing 7.35, which is within range, but it is on the lowest range, right? Their CO2 is at 60, which is high, and bicarb is at 32. This would mean they have fully compensated respiratory acidosis. And this is because the pH is at the very low end of normal, which means the compensation worked because it's still within range. The CO2, of course, respiratory acidosis is going to be high, and the bicarb is elevated at 32 in order to compensate for the acidosis. All right, let's go ahead and look at a table here. So let's say the status is uncompensated. This would mean the pH would be abnormal and only one system would be off. Now, if it's partially compensated, the pH is also abnormal, but two systems are going to be abnormal, right? Both metabolic and respiratory. And then if it's fully compensated, we have a normal pH, but both systems are still off, but the pH returned to normal. The pH is always going to be the one that tells you if the compensation is complete or if it's still in progress. Now let's talk about some steps to analyze ABG results. So this is kind of the step-by-step framework that you need to confidently tackle any ABG question on the NCLEX, including the clinical judgment where ABG interpretation is going to guide prioritization or intervention. So let's go ahead and walk through kind of the major steps to ABG mastery here. For step 1, I want you to look at the pH. Always look at the pH first. This is going to tell you if your patient is acidotic or alkalotic. Now, if the pH is less than 7.35, we have acidosis. And if the pH is more than 7.45, we have alkalosis. Now, if the pH is in range, but it's on the high or the low end, you may have a fully compensated situation. So keep your eye out for that. Now, your step 2 here is going to be to analyze the carbon dioxide. I want you to think the lungs here, right? Let's say your carbon dioxide is 45. This means you're going to have respiratory acidosis because you're retaining CO2. But if it's lower than 35, you're going to have respiratory alkalosis, which means you're blowing off CO2. So a nice little neat trick that I'm sure you've seen before, and I want to tell you now, is that the CO2 is if you draw it right below the pH, you'll see that it's the same range without the 7, 35 and 45. Now let's talk about step 3. I want you to think and look at the bicarb and think the kidneys, right? Because when we're looking at CO2, we're thinking lungs. We're looking at the bicarb, we're thinking the kidneys. Now, if it's less than 22, we're going to have metabolic acidosis. And if it's going to be 26, we're going to have metabolic alkalosis, right? So the next step would be to match the system to the pH. Like, for example, does the CO2 or the bicarb match the pH direction? That's going to be your primary problem. Now, if the other value is abnormal, that means your system is compensating. So let's go ahead and assess compensation. If only one system is abnormal, you're going to be uncompensated. But if all three values are abnormal, you're going to be partially compensated. Whereas if you have a normal pH and two abnormal values, you're going to be fully compensated. Now your NCLEX mnemonic here, Rome respiratory means opposite, right? The pH and the CO2 move opposite, and metabolic is equal, which means the pH and the bicarb are moving in the same direction. So remember, respiratory opposite, metabolic equal. Now for a mini scenario here, let's say your ABGs are reading pH 7.30, so this sounds acidotic. We have a CO2 of 58, which sounds acidotic, and we have a bicarb of 24. Now, if the pH is less than 7.35, we have acidosis, which in this case we do. The CO2 here is going to be high, so respiratory acidosis, and the bicarb is actually normal, so there's no metabolic compensation. This means that we would have uncompensated respiratory acidosis. And the action here would be to support the airway, to treat the causes, such as, let's say if they're on opiates, we're going to need Narcan, right? Let's say they're hypoventilating, we're going to need to open up those lungs and administer oxygen and protect the airway. Let's say they're having COPD exacerbation, right? So we're going to use appropriate interventions to whatever the underlying cause is. Now, let's say that you have a client that has ABG results of a pH of 7.49, a CO2 of 38, and a bicarb of 30. Now, this would actually be metabolic alkalosis, right? And it would be because the pH is higher than 7.45, so it's alkalotic. And the CO2 is normal, but the bicarb is elevated, which means we have a metabolic cause. And since the CO2 is normal, we have no compensation. Do you guys have any questions so far?
So, Professor, it doesn't really matter if the bicarb is high. Once the CO2 is regular and is normal, it's not gonna be compensated. It's not as in it's not partially compensated, right?
So the compensation is always going to rely on the pH,
On
right?
the pH. Okay.
Yeah, it's always going to rely on the pH. And I'll kind of go back to this table here and what it is like I said, if the pH is abnormal, if the pH is still abnormal, you're either uncompensated or you're partially compensated. But if, let's say, both of your bicarb and your CO2 are abnormal, but your pH is normal, that means you probably return to normal, so you're fully compensated. Now, if both of your bicarb and CO2 are abnormal, but your pH is also abnormal, that means you're partially compensated. And if only one is off, like let's say only the CO2, but the pH is still abnormal, then you're uncompensated. So we're going to go ahead and do some more practice here. Let me see if I can pull up some more practice questions for you guys before we do our full application questions. Give me 1 second. All right, I'm pulling up some questions to practice a little bit more here for you guys. But before we practice some more, I want to go ahead and talk a little bit about our test taking strategies here. I'm not going to put a lot of time into it so we can do more practice, but I just want to remind you guys, for those of you that haven't seen this part of my webinar, I know a lot of you have. I do try to include it whenever we do have extra time to talk about it. It's always nice to talk about test taking strategies. We want to make sure that we always prioritize our ABCs, that we're always prioritizing our physiological needs when it comes to Maslow's hierarchy of needs over any other needs like emotional, psychosocial needs. And then we're also utilizing our ADPI, right, which is our nursing process. We're always assessing the situation before acting, unless, of course, it is an emergency situation and it needs emergency intervention. Otherwise, we always want to assess first, right? And this is having a lot to do with questions that ask you, like, what patient do you see first? What action do you do first? What should you prioritize in the situation? We always want to prioritize, according to Maslow's hierarchy of needs, physiological needs before emotional or psychosocial needs. And physiological needs do include pain, okay? And then when it comes to the nursing process, like I said, make sure you gather data. If you enter the room and the patient's down on the floor, you don't want to just call a code, right? You want to go ahead and check their breathing first. You want to check their pulse. And then at that point, you can decide and determine whether you need to call a code and begin CPR. But you can't do that unless you know that your patient is completely unresponsive. So That is something that is good to remember here. And then, of course, last but not least, remember to eliminate answers that are just contradicting stuff. They're just incorrect, they're just irrelevant, and have nothing to do with your question. This will help you to kind of focus on the answers that are closer to the accurate answer and not necessarily have to question yourself so much. All right, let's talk about some practice questions here. Now, let's say our client has an ABG of 7.31. Let's say they're, and actually let me pull up here on the screen the ranges for you guys to make it easier for you to answer. This is how I like to look at it because it kind of helps me remember better. All right. So let's go ahead and practice. So let's say your client has the ABG of 7.31 and their CO2 is at 50, but their bicarb is at 24. What do you guys think this one is?
Respiratory acidosis.
Yes, respiratory acidosis.
Uncompensated.
Yes, uncompensated. Thank you. You're right. And this is true. Why? Right? Because your pH is low, right? And let me go back to my numbers here. Your pH is low, your CO2 is high, right? And then your bicarb is actually normal. So because your pH is low, this means you're acidotic. Because your bicarb is high, this means we have a respiratory, I'm sorry, because your CO2 is high, you have a respiratory cause. And because your bicarb is normal, this means your kidneys aren't even working to compensate for it. So it is completely uncompensated. Now, here's another one. Let's say your patient has a pH of 7.46. Let's say their bicarb is at 30 and their CO2 is at 30 and their bicarb is at 21. What do you guys think that one is? So again, pH 7.46, CO2 30, and bicarb 21.
Metabolic alkalosis.
It is alkalosis, but it's actually respiratory
Respiratory
alkalosis.
alkalosis, and that is partially compensated.
So the pH on this one is normal, right? So it's a little bit alkalotic. It's 7.46, but
Right.
it's still a little bit alkalotic. The CO2 is low, right? It's at 30. So we know we have respiratory alkalosis, and the bicarb is also low, which means the kidneys are trying to compensate here. So because the pH is pretty normal, it means it's fully compensated with respiratory alkalosis. Now let's try one more. Actually, I have two more for you guys. Okay, let's do a pH of 7.28. Let's do a carbon dioxide of 37 and a bicarb of 16. What do you guys think this one is?
What's the P?
Uncompensated
I
metabolic
didn't hear it.
It's
acidosis.
metabolic acidosis.
Yes.
Respiratory acidosis.
Uncompensated metabolic acidosis.
Yes, you're right. It is
I didn't
uncompensated
hear what she said.
acidosis. Absolutely. And the reason why, again, right, our rationale here is why? Because the pH is low, right? 7.28 is lower than the range. So we have an acidotic pH. The CO2 is normal at 37, and the bicarb is going to be low at 16, which means we have a metabolic cause. And there are no signs of compensation here because the pH is still abnormal, so it is uncompensated. All right, let me give you one more here. We have a pH of 7.51, a CO2 of 45, and a bicarb of 30. What do you guys think?
Metabolic alkalosis.
Yes, metabolic alkalosis.
Compensated metabolic.
Did you say uncompensated?
Compensated.
So it's actually uncompensated, but yes, it is metabolic alkalosis. And the reason why is because our pH is still high, right? So we're alkalotic, which means we're uncompensated, right? But our CO2 is normal, which means it isn't respiratory, it's metabolic. And our bicarb is high, which again means it's metabolic. But there's no compensation because our pH is still 7.51. So it is uncompensated metabolic alkalosis. All right, you guys did amazing on that. Let me go ahead and pull up our practice questions here. And I'll have you guys participate with me like you always do. All right, let's pull up question 1. So we have a nurse assessing a client who has been excessively vomiting for the past 2 days following a whole blood transfusion and a dose of furosemide. So we already know here that we have vomiting, right? So let's highlight vomiting. Sorry, it looks crappy. And we had furosemide, which is a diuretic. And this client is lethargic and confused. Their blood sugar levels and serum electrolyte levels are normal, but what test would the nurse prioritize in this plan of care? We have thyroid function test, parathyroid hormone, arterial blood gas analysis, or a renal function test.
ABGS.
Yes. Yes, yes, yes. ABGs are going to be the gold standard here, right? Because this client is having symptoms of metabolic alkalosis. This is because they had excessive vomiting, so they lost stomach acid, and the furosemide administration is telling me that they lost potassium, right? So they're losing all their acids, they're lethargic, they're confused. This means their CNS is definitely depressed, and they could have metabolic alkalosis. Now, let's see here. For option A, thyroid function test, let's talk about why the other answers are not correct, right? So even though thyroid dysfunction can cause certain symptoms like what this client is having, like lethargy, confusion, this would most likely be like on the hypothyroid side. There aren't really any like signs in this clinical picture that are showing us that there's thyroid involvement, right? Now, the parathyroid could have involvement because of calcium if they were having tetany or if they were having irritability in their muscles, but their clinical presentation aren't really showing anything that has to do with the parathyroid. Now, when it comes to renal function tests, again, these are going to be important if we are dealing with metabolic issues. But again, there's not really anything in the scenario showing that we need to assess the kidneys, especially because, again, it read here that blood sugar levels and serum electrolyte levels are normal. So there's not really a reason for us to think that we need to assess kidney function. Now, ABGs are definitely going to be number 1 here. Does anyone want to read number 2?
A nurse is caring for a client who has been diagnosed with metabolic alkalosis. Which intervention should the nurse prioritize? A, encourage increased fluid intake. B, administer prescribed potassium chloride. C, assess the client's oxygen saturation levels. D, assess the client intake and output.
Thank you so much for reading that. So our client was diagnosed with metabolic alkalosis. Now we're looking at interventions, right? So what do you guys think we need to do?
Encourage
That's a B.
increased fluid intake.
Yes, it's actually B. You're
Be
correct.
administered potassium.
Yeah, we need to administer potassium, right? Because metabolic alkalosis means that we usually have hypokalemia with that because our kidneys are excreting potassium as hydrogen ions are being retained in order to compensate for the alkalosis. So if we administer the potassium, we're going to help to correct that underlying electrolyte imbalance, and we're going to help to prevent any cardiac issues that could happen as a result of hypokalemia. So definitely B. That's definitely going to be our main intervention that we're going to prioritize. Now, all the other interventions could still be appropriate, right? But we're talking about the primary one here. And because we have a metabolic issue, we're definitely going to be dealing with potassium because we want to make sure that we're protecting the heart. Now, why didn't we choose A, right? We have Hydration is going to be so important here. However, metabolic alkalosis is caused by electrolyte imbalances, right? Not just simple dehydration. So we can increase the fluid all we want, but that's not going to correct the alkalosis unless we're actually putting the electrolyte back in the fluids that we're giving to this patient. Now, assessing their oxygen saturation levels, this is always going to be a great intervention, right? But it doesn't mean that it's going to be the priority intervention in this case, because in this case, metabolic alkalosis isn't really going to affect their oxygenation as the primary problem, right? So lastly, here we have assess the client's intake and output. And of course, it's going to be important to assess their fluid balance, especially if the metabolic alkalosis is being caused by diuretics or by vomiting. But this alone is not going to correct the issue, right? Assessing is not correcting the issue. So we definitely need to take action here.
Can I ask a question?
Yeah, absolutely.
Okay. Is it was a metabolic alkalosis? Is because is it losing potassium and potassium? Is that why B is the answer?
Yes. So, in this specific scenario here, we have a client diagnosed with metabolic alkalosis. What intervention should the nurse prioritize? And out of these answer options, administering prescribed potassium is going to be it, because when a client is in metabolic alkalosis, typically they are losing potassium, right? They've lost the acid from their body and they're losing potassium. So, administering the potassium is going to be the key intervention, because we need to actually address the underlying cause of the metabolic alkalosis, which in this case is most likely the renal excretion of potassium, right? And the reason why is, again, if we read here, the kidneys are excreting potassium in order to retain the hydrogen ions so that it can compensate for the alkalosis. So administering the potassium is going to help to correct that imbalance. I hope that answers your question.
Yes, thank you.
You're very welcome. And let me see here. All right. And I see somebody saying, isn't retaining hydrogen acidosis instead of alkalosis? So the reason why we're mentioning retaining hydrogen ions is going to be the body is trying to retain the hydrogen in order to correct the alkalosis. So it's not acidosis, it is alkalosis, but the body is doing that as a regulation system, basically, to try to regulate the alkalosis. Thank you for the questions, by the way. All right, let's read this one. So it says, a pregnant client presents with complaints of severe vomiting. Okay, we've got severe vomiting. Here's our keyword, right? Arterial blood gas analysis results show a pH of 7.55, which is on the higher end. And the client is at risk for which of the following conditions? What do you guys think?
Metabolic alkalosis.
Alkalosis.
Yes, metabolic alkalosis. Now, what does this mean, right? In the NCLEX, if you got a scenario like this, it would likely be asking you, what do you want to prioritize as an intervention at this point, right? So we know the metabolic alkalosis is going to happen due to severe vomiting a lot of the times because we're losing gastric acid. This is decreasing the hydrogen ion concentration in the blood, so it increases the pH. And again, it's going to cause metabolic alkalosis. Now, this is going to be a disturbance of a loss of acid and a gain in bicarbonate, one or the other. So let's go ahead and talk about why it's not the other options, right? It's not metabolic alkalosis because we're losing acid. We're not retaining acid, right? So this 7.55 is actually in the alkaline range, not in the acidic range. And then it's not respiratory acidosis. Again, this has to do with vomiting, right? This has to do with losing acid. It doesn't have to do with the respiratory system. And we actually have a high pH, not a low pH. And then respiratory alkalosis, again, this would be if they had given us any other value here, like if they had given us the CO2, then it could have been something more leaning towards respiratory alkalosis, but they only gave us the information of severe vomiting and a high pH. So we know that it was metabolic and we know that it was alkalosis. All right. Does anyone want to read number 4?
A nurse is assessing a 15-year-old client who has been brought to the emergency room semi-conscious with a reported history of nausea and vomiting. Upon measuring his random blood sugar, it is noted to be 18 millimoles per liter, which clinical finding will be in keeping with his diagnosis: A. Warm flushed skin; B. Small respiration; C. Tetany; D. Tremors.
Thank you so much for
B,
reading.
small respiration.
That's
Yes.
B, small respiratory.
Yes, absolutely. Right. So we have a 15-year-old client, they're semi-conscious, they have a history of nausea and vomiting, and their blood sugar is 18. That is super low, right? So we're going to go ahead and say small respirations. Now, in Kussmaul respirations, this is going to be a compensatory mechanism that the body is going to use in DKA. This is going to be deep, rapid breathing, like, right, as the body is trying to blow off all the extra CO2 in order to decrease the acidosis. Now, warm flushed skin, not really likely. The skin here would most likely be dry and warm because of the dehydration. Tetany, this would be associated more with calcium conditions, right? And then tremors would not be specific to DKA. They would be more with hyperglycemia or with acidosis, but not really a hallmark sign. Anytime you hear DKA, you're thinking Kussmaul respiration. So definitely great answer. All right, so we have a client in the emergency department that's being treated for hyperventilation related to anxiety. Now, what arterial blood gas results would the nurse anticipate for this client? And we do have the reference range here. So what do you guys think? So we have hyperventilation related to anxiety. That's the key word here.
That will be A.
That's A.
Metabolic. That will be metabolic alkalosis.
Alkalosis.
Hey, metabolic
Respiratory
alkalosis.
We're divided about it.
Respiratory.
Respiratory alkalosis.
Respiratory.
Right? So they're hyperventilating, they're blowing off a lot of CO2 here. So we're going to have alkalosis, right? We're blowing off all of our CO2. So that means our body doesn't have enough CO2 and we have respiratory alkalosis, right? And this is, again, consistent with hyperventilation. So it is going to be the pH of 7.47, the CO2 of 25, and the bicarb of 26. Now, the bicarb is within the normal range. And this is because it is in compensation, right? The body is trying to compensate for the respiratory alkalosis. Let's look at the other answers here. So for option A, we had a pH of 7.49, a CO2 of 36, and a bicarb of 31. Now here the pH is higher than the normal range, which is still indicating alkalosis, right? It's just a little bit farther from B. The CO2 is normal, and the bicarb is elevated here. So this would actually be metabolic alkalosis, not respiratory. For option C, we had a pH of 7.32, a CO2 of 41, and a bicarb of 22. Now here we have an acidotic pH. We have a CO2 that's within the normal range, and we have a bicarb within the normal range. So this means we have compensated metabolic acidosis. And then for option D, we have a acidotic pH of 7.30. We have a CO2 that's elevated at 48. And then we have a bicarb of 26, which is within the normal range. So this means that this person has compensated respiratory acidosis. So let's go ahead and look at another question here. We have a nurse that is caring for a client with diabetes on metformin who reports muscle twitching. On assessment, their blood glucose level is 70 or 3.9 mmol per liters. Which of the following acid-base imbalance would the nurse suspect in this case? What do you guys think?
Metabolic acidosis.
Metabolic acidosis.
Yes, metabolic acidosis. So metformin can cause lactic acidosis, right? This is a form of metabolic acidosis, and this is because sometimes it can impair the renal system or if the patient is taking too much. Now, this is when this happens, we have a low blood pH because of the acid accumulating and or because of the loss of bicarb. And this can actually cause symptoms like muscle twitching, confusion, and fatigue. Now, the reason why it's not respiratory acidosis is because we have an accumulation of carbon dioxide in the blood, usually caused by hypoventilation, like in COPD, right? It's not really associated with hypoglycemia or with metformin use. And then, of course, the symptoms here would be different. We would have confusion, lethargy, and dyspnea, not muscle twitching. Now, for respiratory alkalosis, this would be if we had a decrease in the carbon dioxide and a high blood pH. Now, this would be like lightheadedness, tingling, and numbness. The presentation would be different. And then, of course, with metabolic alkalosis, we would have an increased blood pH, and then we would have it wouldn't be associated with hypoglycemia or metformin. And of course, the symptoms here would also be different, but we might have some muscle twitching as well. All right, we have a client that is admitted to the medical unit with an NG tube. That's going to be our keyword here, NG tube attached to low suction, right? So which of the following is the client most likely to experience? So we have
Yeah,
B,
metabolic
metabolic
Alkalosis.
alkalosis.
metabolic alkalosis.
Yes.
B.
You guys are right on point with that one. You got that keyword you saw in there. You're like, yep, that's what it is. And it's true, right? Because with clients that have NG tubes attached to suction, this is constantly removing the hydrochloric acid from the stomach. And the loss of that acid is going to lead to the blood having an increase in bicarb levels, which causes alkalosis. All right. And then we can, let's see, we already know why it's not all the other ones, right? So let's talk about this one. This one's a little bit more talking about compensation here, so it's a little bit harder to figure out. So we have a nurse that's caring for a client with a suspected acid-base imbalance. Their ABGs are 7.33, so we have an acidotic pH. The CO2 is 49, so we have an acidotic CO2. It's high. And then our bicarb is 26, so it's normal, but it's kind of on the far end of the normal range. So how should we interpret these results?
Uncompensated respiratory
acidosis.
Yes, you guys shouted it out correctly. It's D, uncompensated respiratory acidosis. Now, our pH was below the normal range, right? Which indicates we have acidosis. The CO2 was elevated, which means it's respiratory. And the base was within the normal range, but it's kind of on the far end. So it indicates that compensation didn't really occur yet. So this is uncompensated respiratory acidosis. Awesome. Now, if it was uncompensated respiratory alkalosis, this would look like a high pH, a low CO2, and then the pH would be below the normal range, and the CO2 would be elevated, right? In this case. So that's why that's not uncompensated respiratory alkalosis. Now, if it was uncompensated metabolic alkalosis, then we would have a high pH and we would have a high bicarb. In this case, the pH is actually below and the bicarb is normal, right? So again, not it. And then for uncompensated metabolic acidosis, we would have a low pH and a low bicarb. All right, for question 9, a nurse is planning care for a client with COPD and respiratory acidosis. Which interventions would the nurse include in the plan of care? Select all that apply. We have assess level of consciousness, monitor serum sodium, check skin turgor, administer diuretics, and encourage pursed lip breathing exercises.
Would it be ABE?
You got some of the right ones in there.
ABE?
AGE.
The answer is A and E.
Yes.
Okay,
Yeah,
A&E.
yeah, yeah.
And you guys all got A and E, so you're
Yeah.
practically correct. I love it. And it's true,
That's sodium to throw me off. Yeah.
right? So, A, why are we assessing the level of consciousness, right? Because we have changes in mental status that can happen with respiratory acidosis, right? This patient could be hypercapnic, right? That's why they have COPD. They could be hypoxic. These are all common complications of respiratory acidosis, and they can show that the patient is worsening. In this case, the patient might need BiPAP. They need ventilation support. Now, encourage pursed lip breathing exercises. This is going to help to promote better exhalation for the patient and to reduce the retention of the carbon dioxide in clients with COPD. Now, this is only going to be used as an adjunct therapy, right? It's not going to be the only thing we're going to do. We still need to do other things as well. Now, why aren't we monitoring serum sodium? This isn't really something that we do for respiratory acidosis and COPD unless for some reason they were having additional like cardiac issues, water retention issues, then we might monitor their serum sodium. Now, checking their skin turgor is going to be relevant for assessing dehydration, but not really relevant to respiratory acidosis. And then, of course, administering diuretics is not really going to be indicated unless this patient is suffering from fluid overload or if they have a specific condition like heart failure. We don't do diuretics just for respiratory acidosis.
Professor, which other intervention can we do at this time?
Interventions for what?
For a patient with COPD who has a lot of acid buildup, he said encouraging pulse-lip breathing exercise, but there is other intervention that we can do. We can't just do only that, encourage pulse breathing. Like in terms of medication, which other medication can we administer at this point?
Yeah, absolutely. That's a great question. Let's talk about it. Let's go back to our respiratory acidosis slide here, right? So, thinking about it with our critical thinking, we know that respiratory acidosis from somebody that has COPD, they're going to be lethargic, they're going to have a headache, they're going to have shallow breathing. And when we see them having changes in mental status, that means that they could be retaining a lot of CO2. And at this point, we would likely be putting them on the BiPAP. That would be the most likely intervention that we would do. If they get bad enough that their CO2 is really, really high, then, and they're of course like losing consciousness, at that point, we might need to intubate them. Now, I used to work in a respiratory unit where we had a lot of patients with COPD. They would come in hypercapnic. They weren't using their CPAP outside the hospital. And they were just retaining a lot of CO2. And what happens to these patients is we would put them on BiPAP. They need BiPAP therapy for a long time, and they really need to be able to tolerate the BiPAP. And a lot of times, because they're hypercapnic, they're confused. They're like trying to pull off the BiPAP, and they don't want it on, and that's something that kind of becomes like a challenge with patients like that. So the main intervention for these patients would be to support their airway and improve their ventilation, which would look like BiPAP use. Again, if their CO2 gets high enough, we would actually need to intubate them in order to improve their respiratory status and to fix the acidosis in the body. So BiPAP is going to be our number one intervention for COPD patients.
Can we use bicarb at this time also, like medication like dopamine? Is it necessary at that point to treat acidosis?
Let me see. Let me pull up a protocol of medications here for COPD patients with, let me see here, my notes. So I can give you a full protocol to remember here. And interestingly enough, like I said, when you have these patients in the hospital and they come in and they're hypercapnic because they haven't been doing their CPAP therapy. You put them on BiPAP. A lot of times they end up becoming more confused. Now, a rule that I also want you guys to remember is if your patient is hypercapnic and they are in respiratory acidosis, and you put the BiPAP on them, but they become unconscious or they seem so confused that they can't take the BiPAP off of themselves. This is another NCLEX hot topic I want you to remember. You can't keep a BiPAP on a patient that isn't able to remove the BiPAP off of themselves. So, like, let's say they have their respiratory acidosis, they're hypercapnic from COPD, and we put the BiPAP on them, and they're starting to like lose consciousness because the CO2 is just building up so much in the blood. At that point, that might need to be intubated as opposed to having the BiPAP on, because if they are unable to remove it off of themselves, the risk here is that, you know, there could be any situation that could obstruct their airway, like let's say they throw up, or, you know, anything could happen and they can't remove it off of themselves. That would be a contraindication. So remember that about BiPAP for the NCLEX. It's kind of like a key tip. Now,
But they could get becomethasone or prednisone or ipratropium also.
yeah, so for this patient, the first thing we're going to do is we're going to elevate the head of the bed, right? We always go from least to most when it comes to interventions, right? So we're not going to let this patient lay flat on their back. That's going to be the absolute worst thing. We're going to elevate their head of the bed. We're going to administer oxygen if needed, right? But it's only going to be low flow because remember, with your COPD patients, if you administer high flow oxygen, this can actually lower their drive to breathe. So, administering too much oxygen to patients with COPD is not a good thing. So, if you were administering it on the nasal cannula, it would be low flow. Of course, we talked about pursed lip breathing. We know that we're going to monitor their ABGs, their respiratory rate, and their level of consciousness. And just like you said, bronchodilators and steroids are also going to be on board for this patient. Now, we might give albuterol, we might give ipratropium, we might give some IV corticosteroids or inhaled corticosteroids if appropriate at that time. We might also give them some medication to help mobilize their secretions, right? Like let's say that they're having a lot of mucus buildup, which a lot of COPD patients do. We might give them some mucolytic medication. And then, of course, if they are really anxious and again, they're not able to keep on their BiPAP, we might give them something for their anxiety, but it can't be enough that will sedate or lower their respiratory drive, right? So if we have to be really conscious about that, about not giving anything that's going to lower their respiratory drive or sedate them too much.
And
But
we can't give them a high oxygen either.
exactly. No high oxygen. And if you do give something for the anxiety so they're able to keep the BiPAP, it has to be like a low dose, right? You have to collaborate with your physician to make sure that it's not anything that's going to cause sedation. Now, again, BiPAP is going to be your number one intervention. Again, you are going to do bronchodilators, you are going to do steroids, right? The bronchodilators are going to open up their airway. The steroids are going to help to lower that that's in the airways. And then if the BiPAP fails or their conditions worsen and those medications as an adjunct therapy aren't helping enough, we might have to prepare for intubation. So that's going to be pretty much the protocol for a patient with COPD. Remember, BiPAP is always number one. Positioning, they're never going to be lying flat, right? We're going to elevate the head of the bed. And then, of course, we're going to administer bronchodilators and steroids as an adjunct to the BiPAP therapy. And then, of course, we need to monitor their ABGs very closely, right? And their respiratory rate. Thank you for that question, by the way. That was an excellent discussion.
Thank you so much for answering.
What was that?
I said thank you so much for those, and it makes a lot of sense now. Thank you.
Good. I'm glad. I'm really glad that helped. And please ask away if you need to know anything else. So last question here. We have a client in the emergency department being treated for an acute asthmatic attack. Now, which arterial, oops, wrong one, right? Wrong color here. Which arterial blood gas result in the late phase would the nurse anticipate for this client? Select all that apply. We have a pH of 7.28, a CO2 of 55, an oxygen of 60, a bicarb of 24, or a potassium of 5.8. What do you guys think?
A,
B.
B, and D.
A and B is correct. So it's actually A, B,
Yeah.
and
And
C.
And
C.
C.
Yep, exactly. And the reason why, of course, the pH is low, right? We're going to be in acute asthma attack, respiratory acidosis is going to develop because we can't exhale effectively. So we are definitely going to be on the acidic side of that pH. And then the CO2 is going to be increased, right? So we're definitely going to have some carbon dioxide retention here. And then the PaO2 is going to be at 60 because of the impaired gas exchange, right? We have airway constriction, and we possibly have mucus plugging the airways too. So we're definitely going to be hypoxemic. That's why the O2 is going to be really low. Now, the reason why we didn't choose bicarb is because HCO3 at 24 is a normal bicarb level. The body may compensate over time, but if this is acute respiratory acidosis, this wouldn't show any significant changes like this. And then a potassium of 5.8 does demonstrate hyperkalemia. This isn't really expected with an asthma attack. If potassium levels do shift, they're not going to be this high unless there's like other comorbidities going on. Well, let's talk about some of the main points that we made today and kind of bring it together with some key takeaways. First, let's talk about what we're measuring, right? pH. pH is going to be that main measurement of that hydrogen ion concentration in the blood, and it's going to reflect how acidic or how alkaline the body is, right? And we're going to remember that normal range of 7.35 to 7.45. Below 7.35 is acidosis, and above 7.45 is going to be alkalosis. And remember to pair that CO2 equals acid, which is controlled by the lungs, and bicarb equals base, which is controlled by the kidneys. This distinction is what's going to help you figure out whether the disorder is actually respiratory or metabolic. And I know it seems really daunting at first, but once you get it, it's like so easy. Honestly, it was like the easiest topic for me on the NCLEX after I actually took time to understand this. Now, also remember how the body compensates. Buffers are going to respond first. They are quick, but they are not powerful. The lungs are going to respond second, right? They're going to change CO2 levels within minutes. And then the kidneys are going to adjust bicarb slowly but powerfully. And it's going to take days or hours to days. And you always want to assess how the body is trying to help and whether it's succeeding. And that's what compensation means, right? Is the body trying to help this patient, and is the body doing it successfully? When you're interpreting your ABGs, you're going to start with that pH, and then you're going to look at the CO2 and the bicarb, and you're going to remember your mnemonic ROAM to see if it's respiratory or metabolic. And of course, you're going to ask yourself if the other system is compensating, right? Like if it's respiratory, is the other system compensating? Then we're going to name it. Is it uncompensated or is it compensated? And of course, they're not just going to ask you to label the imbalance on the NCLEX, right? They're going to want you to recognize the symptoms. They're going to want you to anticipate what complications could come from this acid-base imbalance. And they also want you to choose the right interventions. So I want you to remember to use trends over just using single values and connect the cause to the condition. Now, if you're ever stuck, I want you to remind yourself, what is the pH? What system is off? And what's the body doing about it, right? And then last but not least, I want you to think to yourself, what do I need to do next as the nurse? It's really all about those connections that the NCLEX is going to be asking you about. It's very unlikely that you're going to see a question that says like, oh, the pH is this, the bicarb is this, the CO2 is this, what is it, right? It's more likely going to give you those values, and then it's going to say, what priority intervention do you need to do next? And that's going to test your ability to make those connections between the numbers, what system is suffering, what the body is doing about it, and what you as the nurse need to do next to preserve this patient's life. Now, this does conclude our presentation today. We have a little extra time if you guys have any questions.
And we want to give a shout out to Nurse Adioda Akinola. Hope I call her name right. She passed her NCLEX. Congratulations.
Woo, I love it. Shout out. Congratulations. That is so amazing. I love to hear that. That is incredible. What hard work goes into that. Oh my gosh, it's such a sense of accomplishment. I
I
remember
hope she's on here still.
I hope
I know she
so.
was on.
We're clapping. So I remember checking obsessively. I think I crashed the website when I took it, and I was just checking like obsessively to see if it would show my results, and I was trying all the tricks. So it's really fun, and it's just wild, and it just makes you so nervous, but then in the end you're going to cry tears of happiness. So Oh, well, that's so amazing. Thank you guys so much for being a part of our community here and for supporting one another, because we're all on this journey together, right? And it's so important to have that community and that support, and to know that we're all going through it together. And again, I'm here for you guys. So whenever you come onto these webinars, ask all your questions, write your questions down about whatever topic we're talking about, drop them in the chat, and I'll always make sure to address them. And again, congratulations to all of you that have taken the NCLEX, or those of you that have already passed, and those of you that are about to take it too. I'm really excited for you. You've got this. Trust in yourself. You've been doing all the hard work that's needed. So I'm really, really happy and excited for all of you guys. And thank you for being here and being a part of our community. And I do see a quick question here. On question 5, hyperventilation means CO2 is high or low. So when you're hyperventilating, typically you're going, right? So it means you're not actually expelling enough CO2 out of the body. So the CO2 is being retained and it's building up. So that means the CO2 would be high. Thank you for asking that. That's a great question. Yeah. Well, great. Well, thank you guys so much for everything. I'm going to be teaching 3 classes a week. So if you guys want to tune
Yay! Yes.
Yeah, I'm so happy to hear that you're happy. That's awesome. I love you guys. I love seeing you guys here. Thank you so much for everything. And I hope to
Thank
see you
you
guys in
so
the
much.
classes. I'm going to be doing Thursday, Friday, Saturday. So I'll see you guys there.
Great.
You have a wonderful night and enjoy the rest of your weekend. I will see you guys in the next class.
Hi, I'd like to
Thank
ask
you.
a
Bye.
question before we leave.
Thank you very much.
Thank you as well.
I have a question. Maybe you can help me with that.
Yeah, absolutely.
So I have been doing the readiness question,
Mm-hmm.
and I've been getting like high pass.
Okay.
But when I go through, the section that goes through different details of it, I am still having issue with my physiological adaptation. It's
Okay.
always like the low ones. I don't know why. What am I doing
Okay.
wrong?
So like when it comes to physiology, you're getting a low score in that area?
Yes, like really low. Like it would everything else would be in green, and that
Yeah.
would be in pink.
Yeah, so that probably just means that somewhere maybe you're missing the connection of something, right? Like, because we know that our basic knowledge of the structure of things and what they are and what they do, and the physiology of it is like how they connect, right? How those things like work together, how those parts work together, and how they work the way they do. So I would just say, um, make take a look back at some of those questions that you may have gotten wrong. Does it show you the some of the questions that you may have struggled on the most?
When you finished, you because it doesn't show you at the same time, but when you're done, it's 110 questions. So
Uh-huh.
when you're finished, you can always review, which is still a lot. I still try to, but it's like I'm not connected because even when I do the CAT, I am still getting the physiological adaptation in that. Like I'm not moving from there, and I just want to know what is it that I'm not what I, need to look for, what does it entails, like it's like I'm confused. I'm like, why am I not getting this? Why am I so low in this all the time?
Yeah, I would just say maybe go back to some of the major areas that you're studying and just kind of go back to the connection of like the physiological process of the body of how things are happening. I think that's going to be kind of your biggest key to understanding the physiological part of it, because sometimes that's what we're lacking. Sometimes we're lacking like a foundational knowledge. Like sometimes we know and we memorize how to answer certain questions or how to prioritize certain things, but we're not understanding like the foundational physiological process that's going on behind everything. So maybe try to think back to some of the questions that you may have like been more challenged with or struggled more with, and go back and try to see if you can study like the physiological processes. Like for example, we're not just memorizing like parts, right? We're understanding like what is the job of this system, like the endocrine system. Let's just talk about the endocrine system. Like what is its job, right? What happens if the endocrine system fails on us? Like what symptoms would I expect, for example, if the endocrine system was failing, or the respiratory system, right? The respiratory system is supposed to ventilate, provide oxygen to the body. If it fails, what happens, right? That the patient is going to have respiratory depression. They're going to need airway support. What symptoms would you expect of that, right? So you don't want to just kind of memorize what things look like or what they are. You want to really understand what's happening in the background. So if that's the problem, is the physiologic adaptations, that's what you want to do. Is you want to go back to what's happening in the background. You want to think about like, what's the cause? How does the body respond to it? And what is my nursing priority, right? Like, what went wrong? What's the body trying to do? Like, how is the body compensating for it? Like, for example, let's say the body is hypoxic. The body's going to try to increase the heart rate right now. So now the heart rate's going to be really fast, right? That's how the body's compensating. So what do I need to do? Or for example, if you have a burn, right? The burn is going to cause plasma to leak into the tissues, which is going to decrease your patient's blood volume, which is going to cause the body to vasoconstrict. And then in that case, what would we do about it, right? We would give them fluids, we would monitor their blood pressure, things like that. And so try to remember to study those processes that are going on behind in the background of everything. And then, of course, remember some of the most important physiological processes on the NCLEX. I'm going to go ahead and drop a list here for you in the chat of some of the most important physiological processes on the NCLEX, and just go ahead and kind of and take some extra time to understand those processes. And then, of course, when it comes to other things, not just the body, when it comes to like lab values, don't just memorize them, right? Remember, like, what system controls this lab? Like, for example, the creatinine, right? What system controls it? Well, we know it's the kidneys. What
Kidney,
causes
right?
it? Yeah, exactly. What causes it to go up or down, right? What causes creatinine to increase or decrease, right? If we have AKI, creatinine is going to go up. How does that affect the other systems in the body, right? We're going to expect to see like high hyperkalemia, for example, fluid retention, and what we just talked about, metabolic acidosis. So those would be my personal recommendations when it comes to physiological adaptations for the NCLEX. And sometimes those are kind of the areas where we miss the connection, and they can really make all the difference in understanding all the questions. So I hope that helps.
Okay. And you said you dropped something in here?
Yeah, I dropped it in the chat, a little list. These,
Okay.
I'm gonna type it for you. These are some of the most important body processes to focus on the NCLEX. So I hope that that helps. Yeah, I hope that helps. So it would be really understanding the process of oxygenation in the body. How does fluid and electrolyte balance happen? How does the body maintain thermal regulation? How does the body have intracranial pressure and cerebral perfusion? Talking about the shock and multi-system responses, which I did do a class on that recently. I'm going to do another one coming up. Compensation, right? We talked a little bit about that today. And then also hormonal feedback loops like insulin, like the raw system, like ADH. Those are some really important processes that will kind of help your physiology foundational knowledge to really grow, and then to be able to further understand how to answer those questions.
Okay, I take a picture of it because it's like I'm like, why is this always like everything like, when I finish the whole 110 and I, get the result, it is always high, very high. I mean, very high chance because some
Yeah.
get like maybe in the high 70s, and it says very high chance. But then when I go to look through the thing, I'm like, why am I always getting this one pink? Why it always be pink? What am I not understanding from this one? I'm understanding everything and I can read myself through it and ask myself questions through it to, come to the right answer. But what is it that I am not understanding with this physiological adaptation? What
Yeah.
is
Yeah, that makes perfect sense. And I'm glad that you were able to see that, because it's so nice to be able to see a reflection back to us of like how we're doing and like what areas we need to work on. And I do feel like this was an area that I personally struggled in as well, is like physiologic adaptations and just understanding what's happening behind the curtains, right? Like what's really happening in the body, and how do you make that connection? Like how do you connect the lab to what system it's coming from, and to what symptoms it's causing, and to what I need to do about those symptoms, and to how the body's compensating, and how I need to intervene as a nurse. Like that's really that bulk of physiology and how it connects all the pieces of the puzzle together. So I think if you put a little bit of extra time into understanding those processes, then you're going to start scoring higher on those areas. But it sounds like you're already doing the work, because you're taking the feedback, you're practicing, you're paying attention to all the things that you need to work on. So you are going to do amazing. Just keep doing what you're doing, and trust yourself too.
Thank you, but I don't know. I just know that that physiological adaptation, I know it's going to be a big thing on that NCLEX, and I just wanted to pass that hurdle,
Yeah.
so
Well,
I
the
know maybe
first
I need
step
to
to
get
pass the hurdle is to know about it, and now you know
right.
about it, so you're gonna do it.
I do. I really wanted to know about it. I might have to get if I do another one, because like every day I try to do like when I get up in the morning and do my chores, because I'm not working right now or anything. I'm just home after exams, after my graduation. So I get up in the morning, I do what I have to do, my little chores around the house and everything, and then I will sit down and I will just do like the whole RAT. And then
Yeah,
I would try to go back through, like, let me see, like sometimes I do guess, because sometimes I'm like, I don't understand this, but I'm gonna take a very, a guess.
of
And my
course.
guess always work out right. Like, wow, that was a good guess, and so, but whenever time I look at this thing, it bothers me so much. Like, do I need tutoring for just this particular topic? Because I don't understand why am I getting it wrong. And then like in the evening, I would try to attack the CAT with the 85 questions, because that can give you the answer at the same time, and you can get to read the
Yeah,
rationals and stuff like that. But still, when I get to the physiological adaptation, I am still in the pink. So
Yeah.
like, no, something is literally wrong here. What am I missing? Am I not understanding what this is for me to figure it out or what? So
Yeah, and it sounds like you're on the right track, and you're even making great educated guesses that are leading to the right answers. So you know that your brain is understanding that concept, but sometimes we're just missing those little connections in there. And it's so much content, right? It's so comprehensive. There's so much to understand about these processes in the body that it almost feels daunting to know all of it. So what you're doing is right. You're doing a little bit every day, and you're looking at the feedback, and you're working on all the things that it's telling you that you need to work on. So you're already doing the work, and you're doing amazing. And again, even if you don't know the answer and you're guessing and you're getting it right, then that means your gut knows and you're moving in the right direction. Intuitively, you are building that nursing judgment, that nursing clinical reasoning, understanding, and anticipating things correctly. So you're definitely on the right track. And it does look like we have someone who's going to follow up with you here, one of our amazing instructors. So they're definitely going to follow up with you and discuss it with you and make sure that things are working out for you.
I would appreciate that because I started when I just did the 14 days trial and stuff, and I was going through it, and I was like, everything like was at a borderline, and I was like, oh my God, I don't see myself here yet. And then I said, after my trials, when I said, okay, let me definitely, submit for all of this. And, I started to go through it and everything. And I'm reading the rationals, and I'm reading, and I'm started the lectures. And then I'm
Yeah.
like, okay, then I get to a high, and I'm like, okay, at least I'm going up. And I'm like, all right, I said I'm gonna leave majority of the rats for last, but try to get through that 16 CAT and stuff. And then I started on the rats, and every this is like the fourth one that I did now, and they are all very high. And I'm like, wow, so now I'm from borderline to high. Now I'm at very high, but I need to focus on the physiological adaptation. I need to focus. It's like I need another lecture on that.
Yeah,
How?
no, that makes
Yes.
sense. And you know what? I appreciate you saying that. So, all the classes that are coming up for me, I'm going to make a note for myself to kind of put an extra emphasis on that physiological adaptation part so that you guys can really understand those connections of what's going on in the background. So, I will
Okay.
make sure to include that so that you guys are seeing that more in my webinars, and hopefully that will help as well. So,
Yes. Thank you so much for that. I
you're very
appreciate that.
welcome. And I appreciate you sharing that because I'm sure you're not the only one going through it. So, yeah, thank you so much. Always a pleasure seeing you.
And I will look forward to whoever it is going to follow up with me on that too. Because whatever can help, I need it.
I love it. Absolutely. Yes. And let me know how it goes next week if you do happen to come by and see me in my webinar. Let me know how you're going with that and if things are improving. And like
I
I said,
will.
I'll put an extra emphasis in my webinars as well so we can focus on that.
All right. Thank you so much. I appreciate you.
Of course, I appreciate you, and it's been a pleasure as always. I hope you guys all enjoy the rest of your evening and enjoy your weekend. Take a break because you just did a lot of brain work. So go relax and watch a movie and hang out with your family and get a good night's rest. That's always going to be number one intervention for your brain. So
Thank you so much. Have a great night, Professor.
thank you so much. You too. Have a good night.
Yeah. Bye bye.
Bye.